On behalf of the Better Breathing Institute, I am Dr. Sabrina Brar, and I'd like to thank everyone for joining us for our second webinar of the year. Today, I am delighted to be joined by an international superstar and ambassador for respiratory muscle training, the renowned Professor Bernie Bissett. Professor Bernie Bissett is a Canberra-based physiotherapist with over 20 years of experience specialising in physiotherapy and ICU and acutely unwell patients, with a focus on using respiratory muscle training to accelerate recovery for people in ICU. Bernie has shared her research on IMT as well as COVID-19 recovery around the world, and I'm delighted that she is joining us today to share with us an insight into the life of a patient before, during, and after the ICU unit. Without further ado, I will hand over to Professor Bernie Bissett for today's webinar, and there will be an opportunity for questions at the end of the talk. Thank you, Bernie.
Thank you so much, Sabrina, for that very, very kind introduction. It's an absolute joy to have this opportunity to share some insights about how we, particularly from a physiotherapy point of view, have tried to really make a difference to the patient experience in that journey, particularly through intensive care. And so I would just like to thank the organisers for this opportunity, and hopefully even if people watching don't necessarily work in intensive care, there may be quite a few learnings for people from a really broad point of view, and I hope it'll be interesting. I will in this talk be making reference to specific products. I just want to make it clear that I don't have any affiliation with any of the devices or products mentioned. I'm just sharing with you the things that are available at the moment and that I think are of interest to clinicians working in this space. And also I will be sharing some patient images and videos in this presentation, and just to let you know that patients have provided consent for their images to be used for teaching purposes. So as Sabrina already mentioned, I have been spending a lot of my life since about 2004 focusing on how inspiratory muscle training can help patients in a variety of ways. Most of my experience is focused in intensive care space, and so I continue to work both at in a joint role at the moment between Canberra Hospital and the University of Canberra, and it's fantastic that I still get a chance in my day-to-day work to enable research to happen for clinicians, and I'm really excited to bring what I think is a really current perspective, and a lot of the focus I'll bring this evening is really about trying to share the current best evidence so that you can have that information as well. So in terms of structure, I know logically it would make sense to talk about before and then during and then after, but I'm not going to do that. I'm going to be slightly annoying and actually start during the ICU admission, and then we'll talk about after the ICU. We'll circle back to before ICU afterwards because it's a little bit complicated. So I'm going to start in the middle. Bear with me. What you'll notice about when I talk about the effects of inspiratory muscle training is that perhaps a little differently from some of the other focus in intensive care, I'm not just about the machines that go ping. I'm really keen that we measure things in ICU patients that really matter to the patient. So you're going to hear me talk quite a bit about the experience of breathing difficulty or dyspnea, as well as quality of life. I think it's really long overdue that researchers working in the intensive care space are actually asking our patients about this, because as you will see shortly, it makes a big difference. One of the arguments I want to present to you in this webinar is the idea that, unfortunately, with prolonged mechanical ventilation, there's a really clear relationship to longer-term outcomes. And this kind of slide's capturing this. Respiratory muscle weakness we know is connected with shortness of breath. That is not unique to ICU patients. That is something we've seen in lots of other patient groups as well. The issue then flows on to limited activity because of that breathlessness, which not surprisingly leads to poor quality of life. We know that lots of ICU survivors really struggle with poor quality of life, even for 5 years after their ICU admission. So if we have a way to break that cycle, preferably at the front end, then what a difference we can make to their ultimate recovery. And if that's not a good enough reason to do what we can, I don't know what is. So a really quick overview about why this particularly matters for our ICU patients. A little reminder that just the process of being on a mechanical ventilator where the machine is breathing for the patient, we know quite clearly now that this leads to respiratory muscle weakness. One of the first studies to really capture this was this study here by Levine and colleagues, where they actually looked at what was happening in patients of different durations of mechanical ventilation and could show that those who had between 18 and 69 hours of mechanical ventilation, they had a reduction in the cross-sectional area of the muscle fibers of breathing both the fast twitch and the slow twitch fibers, and also the particular enzymes that we know are associated with muscle breakdown. They were detectable in those who were undergoing 18 to 69 hours compared to just a shorter duration. So this was a really clear signal that it's use it or lose it, but particularly around breathing muscles. And this makes sense. Ask any physiotherapist, if a muscle doesn't have to do its job, what does it do? It atrophies. That just makes perfect sense. And in fact, if you look at what we focus on from a physiotherapy point of view in the intensive care patient population, we're really good at treating peripheral muscle weakness. If people's arms and legs aren't working, then yeah, it's really easy to see that, and we work on that. But check this out. One of the studies by Martin Drees and their group not so long ago really pointed out that at the point of successful weaning from mechanical ventilation, respiratory muscle weakness is twice as prevalent as limb muscle weakness. And yet, it is not yet standard practice for intensive care physiotherapists to even measure breathing muscle strength, let alone let that influence the weaning plan for the whole multidisciplinary team. So it's a bit of a call to action, really. If you need more convincing, there's also been some work that shows that respiratory muscle weakness, not surprisingly, is associated with delayed weaning. So if our patients, particularly those who might have been on the ventilator for days or weeks, if we can measure their maximum inspiratory pressure, which we can do, I'll talk about that in a second, and see how much oomph they've got in their breathing muscles, if that score is less than 30 centimeters of water, we know that's likely to be associated with longer weaning. So really, if nothing else, we should be thinking about and assessing what is breathing muscle strength like in our patients, particularly those who are on the ventilator for more than a few days. They are likely to have trouble getting off that ventilator if we do nothing about it. So the other thing that I wanted to share with you is there's been some nice work looking at what's the best way we could measure respiratory muscle weakness. This is a great study that is brand new. It was just published last year. This is from my lovely colleagues over in Belgium, and they looked at what are the different pros and cons of different methods of measuring respiratory muscle weakness. I've just summarized them for you here. You can see that measuring somebody's maximum respiratory pressure, that's not too bad in terms of sensitivity to predict weaning success. But in fact, the thing that was the most impressive was actually looking at ultrasound measures of diaphragm thickening, that fraction, that actually had the best sensitivity. Now, that's great. And I know particularly in the UK, there's very impressive work with physiotherapists upskilling in using ultrasound to look at diaphragm and lung activity. That's awesome. Again, not yet common practice around the world. Maybe if I gave this talk in 5 or 10 years' time, I'll be talking about, oh, well, yes, of course, all ICU physios can measure what's happening there. I wish we were there. We're not quite there yet. So in the short term, measuring somebody's MIP or PI max, same thing, in a kind of cheap and cheerful kind of way is our best, easy, most accessible approximation of trying to understand whether our ICU patients have a degree of respiratory muscle weakness. So I just would encourage you to have a look at that paper if you're interested in the minutiae of comparing those different strategies. But at this point in time, I still think measuring MIP is worth it. So if we are to measure that maximum inspiratory pressure with our patients, there's a variety of devices we can use to do that. For a ventilator-dependent patient, of course, they're going to have an endotracheal tube or perhaps a tracheostomy. And we, instead of having a lip seal around a mouthpiece, we need to connect our device to that. I've got some examples in those pictures you can see there. And what I say to people is don't be surprised if in a ventilator-dependent patient, your patient's MIP score when you measure it is somewhere between 10 to 20 centimeters of water. And for comparison, me on a good day, I can usually get above 100. Okay, that would be expected for my age and the fact that I'm female and all those kind of different parameters. But certainly our ICU patients can end up on the very profoundly weak end of that spectrum. So some people can be quite shocked by how quickly patients can end up in that zone. If you don't have access to one of those devices, some intensive care unit ventilators have a built-in program within the ventilator itself where you can measure something called negative inspiratory force. Same thing, different name. Again, it's not a pure gold standard, but it will give you the ballpark of where your patient might be. And we published in a guide to clinicians about how you can do this if that's a measure that you might be able to use. It would be great if ventilator manufacturers all made it easy for clinicians to access this kind of information for their patients. So, we should be able to get a grip of whether our patients are struggling with their maximum respiratory pressures and therefore target training of weak respiratory muscles. The exciting new kid on the block in this space, we're particularly excited about this in Australia as we've just had access to this technology, is that there's a new smart adapter with a Bluetooth connectivity, which also allows us to measure maximum respiratory pressure scores. You can see here it's actually designed to interface with a standalone respiratory muscle trainer that's a simple sort of spring-loaded device. But if you connect it to a mouthpiece, you can see like this, that's a normal way that you could measure someone's maximum respiratory pressure, but we've also figured out you could also attach it to an endotracheal tube or a tracheostomy with or without a filter, and we would still be able to use this device to get a nice snapshot of what somebody's maximum respiratory pressure is. The cost of this smart adapter device is considerably less than some of the other tools that physios might have been accessing in years gone by. Might be easier to get hands on, to have that easy sort of simple way of measuring maximum respiratory pressure. This is a screenshot that I did. I was measuring my breathing muscle strength when I did a workshop in Perth just a few weeks ago, and this is proof that I can get above 100 centimeters of water on a good day. And you can see it's a very user-friendly kind of output, and it gives you, your predicted score and what your current scores are. You do have to do 3 attempts, which is just part of the standard process of measuring accurate maximum respiratory pressure. But certainly for our ICU patients, this is a really easy, straightforward way. All you need is that small adapter to be attached to a smart device, an iPad or a phone, and you can get that information reasonably easily. Even if we get our patients to the point of being extubated, weaned from the ventilator and breathing by themselves, we can't afford to presume that our patients are out of the woods in terms of their breathing muscle strength. So we published this paper more than 10 years ago, now really talking about the fact that patients can be weaned but still weary. What we found in a cohort of patients who'd been on the ventilator for at least 7 days, their respiratory muscle strength, even after ventilator weaning, was still quite low, about 40% of their predicted values. And many of these patients were experiencing dyspnea, that really horrible experience of difficulty breathing, even at rest, literally sitting in the chair doing nothing. When we asked them to rank how difficult it was to breathe, their rate of perceived exertion was higher than 0. This is really troubling. These are not a cohort of patients who had necessarily previous lung disease, and they were still finding it difficult to breathe. Not surprisingly, if they're having difficulty with that sense of breathing at rest, if we ask them to exercise, even simple mobility work, in the acute setting, then of course they can be absolutely exhausted without much effort, to get to that point. So it can be a real limiting factor in terms of the recovery for our ICU patients. And if that's not compelling enough, there's another study I would point you to, which looked at if you could measure respiratory muscle strength at the point of mechanical ventilation weaning. Unfortunately, if their MIP score is less than 30 centimeters of water, this is independently associated with 1-year mortality. It is that serious. If our patients have weak breathing muscles at the point of weaning in ICU, they're more likely to die a year down the track. So, and this is even after we adjust for their physiology, the duration of mechanical ventilation, and their BMI. So it's a fairly strong finding, and I think we ignore it at our peril if we're really going to be looking at the long-term outcomes for our patients. When this particular study was published back in 2022, I was absolutely thrilled and relieved that finally other researchers in the intensive care space were paying attention to dyspnea in our ventilator-dependent patients. So this was a fairly impressive study because they looked at 612 patients and they actually asked them what was their experience of breathing difficulty while they were on the ventilator. More than a third could identify that they were experiencing that horrible difficulty breathing. But it's not just about the acute experience. When this research team followed this up 3 months later, there was a real distinction in terms of post-traumatic stress disorder. And those that were able to report experiencing that dyspnea, the difficulty breathing, they were double in terms of the likelihood of experiencing that PTSD down the track. And it did appear to be related to the frequency of those dyspnea episodes prior to extubation. So again, I don't know how we've missed this. Is it possibly just because our patients have been deeply sedated in a lot of intensive care units, and now only as we see a shift towards more awake and alert patients that we have this opportunity to go, okay, but what is the patient experience? And I think we need to be willing to confront this and focus on it as a priority area for where we're putting our therapy energies in this space. So to get back to my argument at the start, I hope I've convinced you that respiratory muscle weakness is real, it's measurable, and there is that connection with the dyspnea and the shortness of breath. And it's not a big reach to understand how it's going to limit people's activity and contribute to poor quality of life. So let's see what we can do at that pointy end. To understand how inspiratory muscle training can make a difference to physical activity as well, it's really important that we can understand how diaphragm fatigue interferes with what our peripheral muscles can do. And the way this works is a really elegantly described reflex called the respiratory muscle metaboreflex. And this basically says, and it's been really nicely documented in lots of different kind of athletes and healthy people, as well as people with problems. When you work the diaphragm to fatigue, that fatiguing diaphragm produces metabolites, and those metabolites travel around the bloodstream, causing, in response, a limb vasoconstriction. So this makes sense to me. The body says, oh my gosh, you haven't got enough oxygen even just to get the diaphragm to do its thing. Okay, we're going to redistribute here. We can't afford to spend oxygen peripherally. Let's bring it back centrally. What does the person experience? They experience leg muscle fatigue. So the way that inspiratory muscle training can do the reverse of that is if we make the breathing muscles, the diaphragm, more efficient in its use of oxygen, if we build its strength and make it stronger and able to do more, then we won't have those metabolites so much, and we will effectively switch that reflex down so that there is potentially more blood supply to the exercising limbs, and the fatigue won't be quite so limiting. So that's the cool thing. We can tap into that. And that's been actually really neatly demonstrated in cyclists, where they were able to measure blood flow peripherally and see that the group that did some inspiratory muscle training could actually have enhanced muscle flow, blood flow in their legs. So really kind of cool idea. And I think once we understand that relationship, then it makes even more sense to focus on training breathing muscles. Does it work? Again, I could do an entire talk just about this. If you look at what happens in endurance athletes, I know we Australians get very excited about sport, but just bear with me here for a second. Across lots of different athletic groups, runners, cyclists, swimmers, we see that focused inspiratory muscle training can absolutely improve their athletic performance. Again, it could be its own talk, but certainly there's clear evidence that we do that. What I would say is we've learned some really key ideas from these athletes, and that is, firstly, that intensity is really important. We want to typically work for strength training at least 50% of the maximum inspiratory pressure. And when we do this in athletes, they report reduced dyspnea at maximal exercise. Now, before I keep going, think about our ICU patients that are incredibly weak to start with. We absolutely get them to maximal exercise, even with just practicing going from sitting to standing or taking a few steps. That might be their maximal exercise. So this is relevant to us. What they've also seen in cyclists particularly is that even just after 4 weeks of training breathing muscles, there is a detectable increase in diaphragm thickness. So this is echoing back to our measures of respiratory muscle weakness as well that we've seen in ICU patients. And let's get rid of the idea that you have to do strength training for 6 to 8 weeks before you're going to see benefits. Even in cyclists, you can see benefits as early as 2 weeks. This is really important for us thinking about an ICU patient context. So, if we're going to use inspiratory muscle training in ICU patients as part of their journey, it's really important that we understand what our principles are for patient selection. We published a really detailed guide about this several years ago, but basically we are talking about, if we're looking at ventilator-dependent patients, they need to be alert and cooperative. We're talking about patients that don't require really high levels of pressure, support, or PEEP, that we're interrupting that circuit is not going to be hugely problematic. We're not talking about patients that are profoundly hypoxic. They're relatively stable with their oxygen. And the respiratory rate factor is important because if they're breathing too fast, they're not going to have enough space to actually do the challenging breaths that we do with inspiratory muscle training. And of course, we're talking about patients who are spontaneously breathing, albeit with the ventilator. Now, for various reasons, your patient in ICU may not be ready to do that while they are on the ventilator. Maybe they're a bit delirious and they're not able to follow commands and be cooperative. You might only get a chance to start that training beyond that. So once they're weaned from invasive ventilation, at this point, we still need them to be alert and cooperative. This is not something I'd recommend in somebody who can't understand what's going on. And either they need to be capable of a lip seal around the mouthpiece, or if they still have a tracheostomy, then of course you could work with that. Again, these patients are probably not requiring lots and lots of oxygen, and their respiratory rate needs to be not too fast so that they've got the scope to do that training. I've got a little video here to show you. This is one of our senior physios in Canberra, and this is one of our patients who kindly agreed to let us make this series of videos. You can see Katie's just disconnected him from the ventilator, and this patient here is going to be doing some big breaths against resistance here. And he's not too troubled by it at all. You can see it's almost like a walk in the park. This is not overly distressing. And this patient was quite able to do quite a good technique. And you can see that Katie's just returned him to the ventilator there. So that would be one set of 6 breaths. In practice, we do 5 lots of that. So we do a total package of about 30 breaths, allowing that rest in between. Now, in my experience, ICU patients are quite okay with doing 6. 6 seems achievable. This is a different training approach to those you might read about in people living in the community or athletes where maybe they breathe against resistance for 20 minutes or half an hour. Our patients, that's too hard usually. So, but 6 breaths is not too bad. You can do anything for about 10 seconds if you have to, right? And so this seems like a really feasible way that's kind of served us well. And with enough explanation and coaching, patients can usually tolerate it quite well. So that's just one example of it being used in practice. That was an electronic inspiratory muscle trainer. I'm often asked, are we just training the diaphragm when we do IMT? Absolutely not. We are also using the accessory muscles. That's been really nicely described by Marine van Hollebeek and colleagues in Belgium, where one of their studies looked at exactly what was happening in terms of the scalene muscles, the SCM, all the oxygenation and utilization. And absolutely, we are definitely training the accessory muscles with inspiratory muscle training. We could do another whole talk about whether that's a problem or not, but in practice, regardless of the balance between diaphragm and accessory muscle use, the benefits that we see are also happening. So what does it do? The most recent, most comprehensive systematic review that I could point you to is this one by Verona. Again, this is a little bit old now. This was published 7 years ago now, and there's been some more evidence. But just to set the scene here, when they looked at a lot of different techniques, they found that yes, inspiratory muscle training does seem to strengthen the respiratory muscles, a mean difference of about 6 centimeters of water. Depends entirely on how you're doing the training, how long you're doing it for, what the intensity is. But on average, yeah, we seem to be able to make breathing muscles stronger for ICU patients. The other really interesting thing is it does seem to accelerate ventilator weaning. All right. And the difference that you'll see on balance, across again the huge variety of studies contained in this systematic review and meta-analysis, about 3 days faster typically. And is that a patient-centered outcome measure? I would say absolutely. Nobody wants to be stuck in ICU even 1 day longer than they have to. But also from a health system point of view, that's actually really powerful data as well. I'll talk about that again in a second. I do want to mention this study that is hot off the press, and this has been again published by Marine van Hollebeek and the Belgian colleagues. They actually did a really interesting, very high quality randomized controlled trial. They compared intensive care patients with 2 different training regimes. One was low intensity, so about 30 to 50% of maximum, and one was, that was a high intensity group. The low intensity group, they intended to be a sham intervention at only sort of 10%. What's really interesting in this study is that both groups actually improved. And although there was no real differentiation between those groups, which left some of us scratching our heads, it's not, I honestly, having looked at this paper in some detail, it's not that inspiratory muscle training didn't work because we didn't have a control group that didn't do it. It's just that the way that they did the low intensity training looks like it had a training effect as well. So it's asked lots more questions about the way we get the patient to breathe. In this study, these researchers got the patients to do a really maximal inspiration from the residual volumes, a really big effort. And if you look in this paper, when they asked the patients, what was the challenge and the difficulty with the integrated breathing, even in the low intensity group, they were saying, yeah, it was really hard. So interesting. We've got a lot more to figure out about how to optimize the dosage, the duration, and the instructions that we give them. Lots more to learn. But yeah, really encourage you to have a look at that article as a really interesting sort of new bit of information, new part of the puzzle. In terms of looking at dyspnea, obviously there's both the previous groups improved. In our study where we looked at dyspnea changes with inspiratory muscle training, only our IMT group had a statistically significant reduction in dyspnea score. This was our randomized trial that we published in 2022. And that's really interesting. We didn't really power this study for dyspnea, unfortunately, but it certainly gave us pause to think about, yeah, it's not just about getting breathing muscles stronger. It is about the impact on our patient's experience. So it was certainly a nudge to keep going in this direction. What we did spend a fair bit of effort on in this randomized trial, where we had a control group that was no IMT compared to a group that did do inspiratory muscle training across two separate measures of quality of life. We used the SF-36, which is a very detailed measure of quality of life, and a simple EQ5D scale. Both showed statistically and clinically relevant improvements in quality of life that were better for the IMT group compared to the control group. This was not the first of our studies to actually be able to detect this change. And again, if we think back to the relationship between breathing muscle weakness, dyspnea, activity, quality of life, this makes sense that it fits together. This idea that doing strength training for breathing muscles could impact quality of life, again, has been challenged by some people over the last 15 years that I've been in this space. But of all the signals, it is the one that is coming up clearly again and again. And if we're going to make a change to people, for goodness sake, let's make it about improving quality of life. I'm just going to show you another set of results. This is something that a randomized controlled trial that we published back in 2016. And this was looking at patients who'd done inspiratory muscle training in that post-weaning period. So let's say, yes, they're off the ventilator. For whatever reason, they couldn't do inspiratory muscle training during that period. But we started that inspiratory muscle training at the point of ventilator weaning or soon thereafter. And if we did just 2 weeks of daily inspiratory muscle training, we saw very clearly, this first diagram is showing you that the IMT group had bigger improvements in terms of their maximum inspiratory pressure. So yes, we could make them stronger, but also the improvements in quality of life were significantly better in the IMT group compared to the control group. So again, we're seeing this signal both if we start inspiratory muscle training while they're ventilator dependent, or even in that post-weaning period, we can make a difference to their breathing muscle strength and their quality of life. So I'm going to take a moment here and do some myth busting about inspiratory muscle training in ICU patients. And let's just see what you think of these. First, my first myth for you is that IMT is unnecessary in ICU patients. Breathing just recovers by itself. What I've just stuck on that slide there for you is a ready reckoner of what normal MIP values would be for different age groups and men and women. So a little moment to have a look at what those normal values might be. And absolutely, pretty much every study of ICU survivors that has looked at the recovery of breathing muscles out to 3 months, 6 months, and even a year, very rarely are they recovering to what the predicted normal values would be for these patients. So even if patients can breathe independently, enough to get off the ventilator, that's one thing. Is it enough recovery to actually do their activities of daily living and to get back to being a fully functional member of society? Hard to say. And I think it would be very presumptuous to think that just normal breathing is going to be sufficient. So I would say that is a myth, and I would really challenge people to think about that. Myth number 2 is that inspiratory muscle training is dangerous in ICU patients. I've been told this a couple of times. What I would have to say about that is that the data does not support that position. We've done several studies looking at safety and feasibility. Our most recent one was published with Mark Nichols and colleagues in Brisbane in Australia. And we looked specifically at that latest device, the electronic inspiratory muscle training device. And we were able to show that there was no major adverse events across 197 sessions across 2 centres. We had some minor events across some participants in about 10% of sessions. But if you have a look at what those events were, a transient rise in their blood pressure, a transient rise in heart rate, and an increase in respiratory rate, I I can't help but say, I don't think these are adverse events. This looks to me like a normal physiological training response, right? So we have to be really careful how we capture and report changes in physiological outcomes in these studies. And I think, be really careful, because if people say, oh, look at all these adverse events, then we could definitely throw the baby out with the bathwater. So compared to many other interventions that intensive care patients experience, inspiratory muscle training is incredibly safe. Now, caveat, of course, we have carefully selected which patients would be appropriate. We're not saying it's for everybody in every situation, of course not, but in appropriately selected patients, really difficult to find examples of where it's caused harm. I'm just going to briefly comment in the safety category about whether we need to entrain oxygen into a circuit. If we're disconnecting somebody from the ventilator and we're getting them to breathe against resistance, when a lot of hospitals are trying to introduce this new technology, they've said to me, Bernie, the consultants are quite nervous about actually taking them off the ventilator with no oxygen. Can we bleed oxygen into the circuit? The short answer is you can. So you can see you can hook it up if you need to. But in the study I mentioned before, we looked at feasibility and safety parameters. There was no difference in terms of desaturation. So basically, just being off the ventilator for 6 breaths at a go, these patients don't desaturate anyway. So I cheekily suggest that you can entrain oxygen if you must, but you're probably treating consultant anxiety about it. That's probably all you're doing. So it's absolutely not necessary. But if that's going to be a deal breaker between the consultant saying, yes, you can do it, or you can't, then, by all means, all right? Okay, myth number 3 is that you can just adjust the ventilator to give inspiratory muscle training. Just adjust the trigger sensitivity. It's the same. Sad to say, there is no good quality evidence that supports ventilator manipulations as inspiratory muscle training. The couple of studies that are out there are very unconvincing and say, oh, it didn't work. However, when I was presenting at this conference in Perth just a couple of months ago, we had some great discussions about how what we're doing with inspiratory muscle training, it's not purely a physical thing. It's not just about adjusting resistance and trigger sensitivity. There's a lot of psychology to breathing. And for patients who are starting to regain that independence, understanding that being briefly disconnected from the ventilator and doing 6 hard work breaths and then going back, that probably creates a sense of mastery, right? Like, oh, I can do it without the machine by myself. And that is possibly part of how the inspiratory muscle training is working. Not just, yes, we know it can build strength, but maybe it's also building confidence and mastery. So I'm now partnering with a psychologist in Perth. We're going to start exploring that and trying to understand the psychological potential benefits of doing inspiratory muscle training too. Short to say, basically, no, there's no good evidence that just playing around with trigger sensitivity is going to work it out for you. And can I also say, often when people have used this technique, they have done it in unconscious patients as well. I find this deeply troubling, right? Just because somebody appears to be unresponsive and unconscious in a bed, we must not presume that we aren't causing distress or trauma at some fundamental level by giving them intermittent suffocation, essentially, right? So we need to make sure that our patients, to do this safely, are awake, alert, and able to understand, yes, it's going to feel like difficulty breathing, but it's just like a short sprint and then you get some recovery. If we can coach them through that, they'll have a very different experience compared to just doing stuff to the machine that makes it feel like it's really difficult to breathe in someone who's delirious or unconscious. Just in case you're curious as to which techniques people are using, one of my fabulous honours students a few years ago, Ellie Hearn, did this neat survey of physiotherapists around the world and said, what are you doing in inspiratory muscle training? What techniques are you using? And I'm just going to point out that unfortunately, adjusting in inspiratory trigger was in that list, as was incentive spirometry. I'm really kind of disappointed that physios think that incentive spirometry is anyway equivalent to inspiratory muscle training, because you aren't able to continue to adjust it as a graded resistance over time. I wouldn't put it in the same category. And in fact, incentive spirometry is in one of the top 10 not recommended techniques by the Australian Physio Association in surgical patients. We could talk about that as well. But anyway, for people to muddle those up, again, it's slightly problematic. Fortunately, we've seen a great increase in the number of ICU physiotherapists using some kind of threshold device where you can actually measure the resistance and apply it in a really systematic way and individually titrate each of those treatment sessions, which is, again, probably the evidence-based way to do it. So that's heartening that we're seeing an increase in usage by ICU physios. My myth number 4 for you is inspiratory muscle training is expensive. compared to what? So again, thinking about the cost of an intensive care admission, one basic spring-loaded device, to give you an Australian context, let's say about $100 to buy one of those. And then one of the most recent reviews I could find about the costs of intensive care beds, a mean daily cost is between $966 to $5,000 a day. Even in a cash-strapped health system, I think it's not hard to make the argument that access to this equipment to deliver inspiratory muscle training very quickly pays for itself. You want to factor in physiotherapist time? Knock yourself out. You're still miles ahead as soon as you have the argument of potentially accelerating ventilator weaning by 3 days. Very easily we can make that argument. So I often encourage physiotherapists that are trying to implement this in their intensive care unit to take these facts and figures back to the ICU boss and go, let me help you. We can make this better and it's going to pay for itself stupidly quickly. So hopefully if people can look at the evidence and the data, they can make smart choices about that. So I've given you the myths. Let me just talk through a couple of what I call truth bombs as well. So the first truth bomb is that ICU patients have to be alert to actively participate in inspiratory muscle training. I alluded to this earlier. Sedation will be a deal breaker. If you have an intensive care unit that has not yet embraced the idea that minimal sedation, maximizing alertness, giving ICU patients that opportunity to actively participate in their care, that's got to be crucial. That's got to be part of what we do. And so addressing sedation barriers might be the first thing you can do before you can even think about implementing it. And supervised inspiratory muscle training is crucial. We're not talking about something that is done in the background to a patient. You're talking about a coached intervention, and physios can upskill in this very fast. And many are delighted to discover that once they are familiar with it, it takes less than 10 minutes a session. And that's allowing for plenty of time for breaks and recovery and encouragement and all that sort of stuff. This is not a very labor intensive or time consuming intervention, but potentially very big return on investment for your patient, not just in the short term, but in the longer term as well. So to summarize, I guess, thinking about that ICU stay, what are the indications for when we'd use it in ICU patients? So if they're still ventilated, if they can tick all these boxes over here, certainly your patients who are 7 days or more or have difficulty weaning from the ventilator, unless there's a reason not to, I'd be jumping in there, knowing that high intensity interval training is safe and likely to give you some pretty good benefits within a short space of time. And maybe in those who have followed weaning from mechanical ventilation, again, if they were ventilated for more than a few days, that just 2 weeks of daily training is likely to give you pretty good benefits. And if you want a step-by-step guide, we've already published that. I've got the links there for you on the slide. So I think I'm going okay for time. Let's talk a little bit about beyond the ICU and what matters there. So if we're thinking about which patients are at risk of inspiratory muscle weakness beyond the ICU stay, we've already talked about those that were ventilated 7 days or longer. Do know that the longer that they're on a mechanical ventilator, the more weak and challenging it may be. And if you think, oh, don't worry, our patients get up and mobilize, so we don't need to do inspiratory muscle training, I hate to break it to you. Early mobility is awesome, and yes, we want to go there, but it doesn't protect you against inspiratory muscle weakness. We demonstrated that in our hospital years ago. We did a little sub-analysis of one of our randomized trials that tried to identify which patients have the best responses to inspiratory muscle training. Those who have sort of moderate to high levels of baseline MIP tend to get the best return, and moderate to good quality of life. If they're really, really weak, then using this simple spring-loaded valve type device might be too difficult for them. Fear not though, because since we did that study and that analysis, the electronic device that you saw in the video, that actually has a much broader range of training pressures and can go much lower. So one of the things we did in our feasibility study was showing that using the electronic device allows us to train many more patients at the lower end of the spectrum. So that's great. If you have a patient who's an ICU survivor who also has a background of COPD or heart failure, there's already really clearly established benefits of inspiratory muscle training in these populations. It can't be nuts not to use their inpatient stay after an ICU stay to get them going on that, or maybe even their rehab time. Use that as a window of opportunity to get them going on something that's likely to give them benefits in the longer term. But even if they don't have any of those diagnoses, if you've got any patient who's an ICU survivor that's telling you that they've got dyspnea, particularly at rest in the days and weeks after ventilation, be really suspicious that there's at least a degree or an element of respiratory muscle weakness contributing to that, and think about that relationship I've described. If we can make their breathing muscles more efficient, then we potentially can make their legs have more access to blood supply, and therefore the fatigue is going to be less of a limiting factor. It's one of those situations where you've got everything to gain and probably nothing to lose. So I think it's worth a shot. I'm also going to quickly mention we have seen in patients who have had a history of COVID and ICU admission, where I do know of at least one study where they've shown inspiratory muscle weakness is still detectable up to 6 months following extubation. So this isn't a cohort of people that didn't have access to inspiratory muscle training. I would really like to think that that is modifiable. So again, if someone's had COVID, maybe that's a group that we can focus on. I often get practical questions about what if you've got a patient who was in ICU, maybe now they're in the rehab or they're in a ward, but they've still got their tracheostomy. What about doing inspiratory muscle training then? Absolutely, we're still going to use that access through a tracheostomy, the same kind of pattern of training. I would suggest 5 sets of 6 breaths, at least 50% of their maximum, and increasing that so it's just at about this, they can only just get that 6th breath and then they need a rest. That's the sweet spot. Obviously, with these patients, though, we're not returning them to the ventilator, we're just putting them back on air, or whatever their oxygen level is, the baseline. The big thing, of course, is if they have a cuff deflation at the time as their baseline, we need to inflate that tracheostomy cuff while we're doing the inspiratory muscle training so we don't have air leaking everywhere. And we need to be very reliable physios and make sure we return it to the original cuff setting afterwards. So again, that's one of those things that people have learned by trial and error and go, oh yeah, we do need to make sure that when they're doing their respiratory muscle training, that it's only going through their trachea and not leaking around. I did mention COVID before, and I just wanted to mention this one study that was one of the very early first movers in terms of looking at the post-weaning ICU patients. It's a very small study. They only had 21 inspiratory muscle training group, 21 control. Very similar prescription to what I've described, except that they did it twice a day, 5 days a week. So whew, that's kind of cool. And they looked at dyspnea and quality of life and 6-minute walk test. And I got to say, all of those things were favorable, even in this small study. So again, for a less than 10-minute per session intervention, if you can help improve someone's exercise tolerance and quality of life, even within that sort of acute post-weaning phase, then what a great opportunity to make a difference in the longer term. I also couldn't help but bring you this little study, which is not actually specifically about ICU patients, but there have been some great systematic reviews looking at IMT following stroke. And I just wanted to highlight that we're seeing more and more studies with evidence that doing inspiratory muscle training following stroke may be beneficial for several reasons. Firstly, that we're seeing increased exercise capacity. We understand that relationship, metaboreflex. Yep, that makes sense. All right, so that's great. But also, hang on, let me just shut down that. The other reason is in stroke patients, there is a reduced risk of pulmonary infection if they've done inspiratory muscle training. Ha! How wild is that? That is not something that we've even looked for in our ICU patients, but they're showing a fairly consistent relationship that if you want to protect your stroke patients from having more chest infections, then inspiratory muscle training, again, low risk and potentially really important benefits for these patients. So if you've got an ICU survivor who's also had a stroke, again, I'd be really motivated by this emerging evidence. Again, there's only a small handful of studies, of course, and you won't yet see that in the guidelines for overall stroke management yet. These kind of systematic reviews are only published relatively recently. But there's every reason to think that this is just, going to become a stronger and stronger signal. So I wouldn't wait around. If I was a clinician working with patients in that space, I'd be looking at inspiratory muscle training. Okay, and this is a sort of longer term, further down the track paper that looked at COVID recovery. I've talked about sort of in the post-weaning space, but I just wanted to mention there is at least one study that looks at long COVID patients, so well down the track. It is self-reported in this particular study, but when they did 3 lots of IMT, 6 lots of 6 breaths, they did 80% of max. So that's quite high intensity and 20 minutes total. Now, remember, these are not ICU patients, these are community dwelling patients. But again, really important if we look at measures of dyspnea, this study again showed that those patients who did the inspiratory muscle training reported better scores in terms of dyspnea, better quality of life, and again, they had more exercise tolerance as measured by the 6-minute walk test. I'm probably sounding like a broken record by now. Like, it's a really consistent message. That relationship between better breathing and better activity and exercise is really clear across the board in lots of different patient groups. So if you are working in that post-ICU space with lots of different diagnoses, it's worth thinking about. The other thing that I wanted to mention in terms of working beyond hospital discharge and into the community is that smart adapter that I mentioned before, where you could use it to measure maximum inspiratory pressure. It's also designed to attach to a spring-loaded IMT device, which potentially the patient might use at home and into the community. The really nice thing about this smart adapter is it gives the patient really clear information about their training on their own personal phone. If they had one, they can see their IMT sessions, they can see their progress. And for many patients who find that really rewarding and motivating, that's a really exciting development where they can continue to build their breathing muscle strength, beyond the walls of the hospital and into the community. If we're saying that it takes, at 6 months, there's still detectable weakness, there's probably still a fair bit of work to do in terms of recovering that. Okay, so I just want to now cycle back and just mention briefly what happens before the ICU. Now, the reason this is such a short section is many of our patients we don't get to see before the ICU because it's an unplanned admission to intensive care. I'm very realistic about that. But there is a small subgroup of our patients in ICU who are there because they've had elective surgery. The most common surgical cases that we see typically in ICU are your cardiac surgery patients, your major abdominal surgery patients. And oh my goodness, is there some evidence that we need to talk about? This is hot off the press, published just last year in the Journal of Physiotherapy. This is a systematic review and meta-analysis looking at inspiratory muscle training that's delivered prior to cardiac surgery in this fairly significant 645 patient trial of quite reasonable quality. There is a lower risk of post-op pulmonary complications. We more than halve their risk of post-op complications if we deliver inspiratory muscle training preoperatively. Now, if I was a cardiac surgeon, I'd be like, excuse me, I want all my patients to be getting this because it's going to have a massive impact on their outcomes. But wait, there's more. And in terms of the length of stay in hospital in the patients that have had inspiratory muscle training as a preoperative intervention, there is a reduction in hospital stay of maybe 1.7 days, something in that ballpark. All right. So again, in terms of the patient experience, in terms of the cost to the hospital system, we should absolutely be putting energy into these patients because it can certainly make a difference afterwards. And this most recent cardiac surgery stuff echoes the Cochrane review that you will find that has looked at combining cardiac and abdominal surgery patients. This again is not quite so new, but fairly convincing evidence that we can reduce the rate of postoperative atelectasis and pneumonia in our abdominal surgery patients by doing this preoperative intervention. And again, that has consistent signals that it reduces hospital length of stay, which I think can only be good news. So I would like to think that this evidence is becoming more and more implemented, and that certainly if physios have a limited capacity, that we need to really look at this data and think about where are we spending our energy? Are we just dealing with mopping up post-op pulmonary complications and people, on that end, or can we jump in early and prevent some of these complications even before they've landed in the ICU? So much so that the Royal Australian College of GPs in Australia actually now recommends inspiratory muscle training to prevent post-op complications. And I've got a link there to their guidelines that they have that you can see right now, where they're saying, oh, here's the evidence. We really need to recommend this. And I think that if I was a patient going for one of these major surgeries, why wouldn't I invest some energy in that work up towards that surgery to reduce my risk of complications and to get me out of hospital faster? Yes, please sign me up. So there we go. Ooh, I think I've managed just in time. We've covered thinking about the ICU admission. We've talked about before, during, and beyond the ICU stay. And we've also talked about how new technology can really help us to make a difference to our patients. So I am going to wrap it up there and hopefully have some time for Q&A. I will stop sharing and hopefully we'll be able to see some questions. Oh, I might even be able to see some questions now. So Sabrina, I can't quite see the questions. If there are any questions online, maybe you can let me know.
Read them. Firstly, Bernie,
Yeah.
that was absolutely brilliant. I could listen to you all day. I say that with the utmost sincerity. So thank you so much for that wonderful presentation, your talk, your time. I know it's quite late in Canberra, or very late. It was really wonderful. And I guess I actually did have a couple of questions I just wanted to ask initially. You've presented such compelling evidence that really is now starting to be illustrated over a number of years. But yet, as you've said, IMT is still not standard practice. Why is that?
That is such a good question. I mean, if you take a step back, what's the argument that between good quality evidence and implementation, what do they say, 17 years or something is the gap? Um, it is changing. It's changing slowly. And I think there are some barriers. Access to equipment was a legitimate barrier for a lot of places, but that's changing as well. I think, hospitals fairly readily stock incentive barometers for many years, and there's really dodgy evidence suggesting that perhaps that's not a good use of, hospital funds. Wouldn't it be great if instead of stocking those devices, we could spend, the equivalent funds on actually something that's evidence-based? So I often have conversations with clinicians saying, well, what is your hospital already stocking? What could you suggest could be, switched around? And if you make that argument at a neutral cost, then often that's good. One of the spaces that people are having success with is in that pre-op or the ERAS, kind of the early surgical planning kind of stage. There seems to be an appetite in terms of funding in different health systems to look at investing in equipment and interventions there. And then you kind of perhaps getting flow on into other directions. So I guess cost and equipment is one thing. Another aspect is, are we teaching people about it? I've been really lucky that I've been able to spend the last several years doing workshops in different countries and sharing what I've learned and really practical tips. And it used to be that I'd go into one of these sessions and ask people, has anybody used this before? And maybe see one or two hands. Now I've got rooms full of people going, yes, I've had a go, but I want to know the next level. So I think it is starting to change. Ellie Hearn's study where she was looking at international practice, she showed that the previous survey said, look, about 5% of ICU physios were using inspiratory muscle training. This was more like 60% were actually saying, yes, we have used it. However, if you actually go and do a point prevalence audit of what interventions are being delivered, which one of my current PhD students, Caitlin Ironside, has just done, it's a bit depressing in terms of the actual usage. I think there's still probably a very conservative approach so far. So I think it's in the early days of the transition towards new technology, but hopefully people can be motivated by the quality of evidence behind it and also be willing to have difficult conversations, introduce, the step-by-step way to do things, and yeah, be brave about being innovative in your hospital, your intensive care unit, or your clinic, wherever it is. And the number of people that come back to me and say, hey, like once we implemented it, actually wasn't scary at all. Like compared to lots of other things we do, like honestly, mobilizing a complex ICU patient with all their attachments is far riskier, I think, than doing inspiratory muscle training in somebody who's an appropriate patient to do that in. The
Mm,
risks are tiny and the benefits are great. So I
yeah.
think, can I be optimistic still and say, well, I think we're still on a journey. And the more we talk about it and share ideas and compare experiences, hopefully the more it will change.
Yeah, I mean, that was a great answer. I think there's always that underlying answer that is education, which is what you've just ended on. So hopefully more people start listening to your talks and reading the evidence. I love the way that you set out really clear truth and myth busters. That's what people need because I've worked in a hospital and people are a bit anxious if it's the first time they're implementing something. So yeah, I agree. I think firstly, in terms of the Q&As, the overriding feeling is, well, everybody's just saying thank you. So thank you, thank you for your talk. And there's a couple of questions about incentive spirometry. Somebody, Stavro, has written quite specifically, would you suggest incentive spirometry or a threshold device for a 20-year-old woman with pneumonia and in danger of intubation?
Um, okay, so it depends on what you're trying to treat here. There's not. incentive spirometry was supposed to theoretically help with an atelectasis problem. If they've got pneumonia, is the problem a sputum clearance problem? In which case, neither inspiratory muscle training nor incentive spirometry are going to be particularly helpful. I think you need to look at other sputum clearance interventions, I guess. Um, without knowing more complexity to that, it's a really curious question. I, Honestly, I can't think of a single time I ever recommend incentive spirometry just because the evidence to support it is so poor. And there's usually other interventions that will be more effective. I wouldn't even think, oh, look at me not advocating for inspiratory muscle training, just to show that I'm not completely biased. I don't think it's a magic bullet. Ins Inspiratory muscle training is not a sputum clearance intervention. Having said that, sometimes you actually, as patients are using high pressures, they might actually ship some sputum, but you wouldn't use it deliberately to clear sputum. You are going to use it to ultimately reduce work of breathing and reduce dyspnea. That's kind of the direction that you're going in. But I would think if you've got somebody who's trying to avoid an intubation, then you need to look at what other skills you have. Do they need some invasive suction? Do they need some positioning and some percussion? Like there's other things I would try. I wouldn't, if somebody has a very high work of breathing and is about to be intubated, that's probably not the right time to be looking at inspiratory muscle training. It's not a rescue therapy of any kind.
Mm.
If they're on the ventilator for a few days though and they're stabilized, let's have another conversation about that though.
Yeah. And I mean, there's another question, you've sort of answered it already. Somebody said if an incentive spirometry is the only spirometer is the only device available, would you recommend it? I mean, that's a slightly mean question.
Yeah, look, I mean, there's no evidence that using that device is superior to, not using it at all. So I would like my big risk with it is that you see patients saying, "Oh yeah, I've sucked up all the balls on my incentive spirometer." Oh, I'm doing a terrible Australian accent here. I've sucked up all the balls on my device, and I've done my physio for today. And if they're doing that instead of actually mobilizing or doing other interventions, then I think we've done them a disservice. We created more plastic in the world. It's not that there's no suggestion that it's actually going to make them better. I would actually do more active whole body techniques if I could, rather than incentive spirometry.
Mm. And somebody else asked about the training protocols, but you've mentioned that your 6 breaths, five sessions at 50% MIP.
Yeah.
Another question that I had is, where do you foresee there are gaps? And this is a very open-ended question, but what are the big gaps in our research knowledge? What would you love to research next?
I'm so glad you asked. So as I mentioned, like I'm really interested in the psychology of breathing side of things, and I'm really excited to work with my
Mm.
colleague in that space. But where there's a really big gap, and I know there's physios around the world that are starting to get experience and share knowledge, pediatrics.
Mm.
So everything I've talked about has been based in adults. And so there's physios around the world that are being brave and trying this with pediatric intensive care patients. So I know of physios in Ireland, in Singapore, in Malaysia that have reached out to me and go, hey, I know that it's all in adults, but we've got this patient and it seems like it could be useful. Would you give it a go? And I'm not a pediatric physio at all, but we could logically kind of extrapolate from what we knew. And I've got to tell you, these physios are having remarkable success. So I'm desperately saying to them, please publish these as case studies, case series, get it out there because people want to learn from each other. When I first started working in this space, literally my first few publications were just a case study and, a case series of 10 patients. Look, this seems to not break them and maybe make them better. Before you get to randomized trials, you need that early evidence. So definitely pediatrics is a space.
Mm.
And there's more and more interesting emerging evidence in other sort of neurological populations. So even things like Parkinson's disease, believe it or not, you wouldn't necessarily think of them as having a lot of respiratory issues. Actually, quite a lot of patients with Parkinson's disease are struggling with sort of respiratory aspects of their condition. And so that's another really interesting space that people are looking into.
Mm.
There's so many places to go.
Yeah, I think you're so right about pediatrics. Obviously, there's often different ethical considerations and barriers to people producing that research. But certainly when I've been at ERS, I know in Brazil, there's a big cohort of physiotherapists who are using IMT on their pediatric patients, and the results are fantastic. So actually, as you said, if they just demonstrate it as a case study and then we have a case series, that's how we start building up this portfolio.
Absolutely. And it's going to be one of those things like in adults, it's not for everybody. It's not always appropriate. What I would say is when physios have communicated with me from around the world, like don't do it in a 2-year-old that's really distressed and can't understand the logic. That's not appropriate. But hey, if you've got a 12-year-old with a incomplete spinal cord injury that is really keen and motivated and really desperate to try to get some independent breathing and there's potential to make a difference, my goodness, wouldn't you give it a go?
Mm.
Like I think there's, we need to share examples of when it's gone well, share examples of, oh no, like it doesn't really work in this kind of situation so that we can, as a group of clinicians, learn from each other. We absolutely need to keep doing that. I hope we could keep doing that for the next few decades.
Yeah. I just wanted to cheekily ask one more question before we close. We obviously talked, the whole talk was about inspiratory muscle training. And I understand that there's a difference as to why you would use IMT versus EMT. Do you ever use EMT in the patient journey that you've just spoken about, and where would
Yeah, so my entire experience is 100% in inspiratory muscle training. I've never used or explored or played around with expiratory muscle training, but you know which professional group is absolutely getting excited and doing research in this space? It is the speech
yeah.
pathologists. So absolutely, I mean, if you look at the literature, like 95% is inspiratory. There's a teeny tiny bit of expiratory, but it's a growing area of interest, particularly around phonation and cough and swallow and that kind of stuff. There's potentially an application there. So even at Canberra Hospital, I know there's some speech therapists that are looking at expiratory muscle training. And I'm like, great. Like this does not have to be a physiotherapy specific thing at all. Like the more clinicians that we can have engaged in exploring and figuring out what's the optimal dosage and which kind of patients does it work in, then fantastic. I
Mm.
would just put a small little idea out there. The few studies that I've looked at that have combined both inspiratory and expiratory muscle training at the same time in the same patient don't tend to go so well. It's almost like the effort kind of cancels each other out in some way. So I'm not yet convinced that you should train both at once. Watch this space, maybe I'm wrong, but there's not a lot of evidence that convinces me that that's a good idea and maybe some signals that it's potentially not as good as just training one at a time. So
Mhm.
again, like early days, it'd be great to see what people find out.
Yeah, I guess even just basic logic, you wouldn't necessarily go to the gym and train bicep, triceps at the same time. You're going to get muscle fatigue, and your form would not be correct. So I think we actually answered somebody's question that said, is there evidence in dysphasia? I think that's probably maybe more of an EMT sector, but yeah. Anyway, Professor Bernie, thank you so much. It's honestly been a really, really great webinar. So yeah, I really appreciate your time. I hope everybody's enjoyed it. And
My
I'll let you
pleasure.
get some rest.
Look,
Look
so
forward,
great talking to you, Sabrina. Thank you
yeah, and
for the
you look forward to
opportunity.
seeing you soon. Thank you, Bernie.
Pleasure. Bye.
Bye.